position in Cambridge. I wanted to avoid saying Cambridge, England, because I thought everybody would know where it was. And we're going to talk today about unmet clinical need in severe asthma. I was really pleased to hear Tonia's talk right at the beginning, where right at the top of one of her pillars of priority was education on OCS stewardship. And a lot of what we're going to be talking about today is around OCS stewardship. I do realize, and it's very humbling to reflect that we are in a very fortunate position in the United Kingdom compared to this part of the world in terms of biologics provision. But what I intend to show you, I think, is how we've used our local data, both regionally and at a national level, to see where we can improve our asthma services. And it would be really great afterwards to have some conversations with you about how you might use some of your data to lobby for change. Okay. I don't really have any relevant declarations for this presentation, declarations of interest. Quick talk through some numbers and definitions. Firstly, actually, can I just check, can you all hear me clearly? Yeah, do I need to shout? Okay, is that better? Yeah, okay, thank you. So I need to stay just here. I'll try. So firstly, how many patients have severe asthma? So this is data published a few years ago. If you take 100 patients with asthma, 24% will be at GINA step 4 or 5, so on high-dose ICS LABA with or without another controller. Of those, 17% will have difficult to treat asthma. They'll have poor symptom control despite being at GINA step 4 or 5. And if you then optimize inhaler technique, optimize their adherence, and treat treatable comorbidities, you'll find that a true prevalence of severe asthma is, in this particular study, around about 4%. In reality, in the clinic, we don't spend a great deal of time trying to label patients as difficult or severe asthma. We treat the whole patient, and some patients with difficult asthma will, of course, end up on biologics. So just the definitions, as I say, you'll see these banded around difficult asthma and then severe asthma. Severe asthma, once you've treated the comorbidities, taken trigger factors away, concentrated on adherence, and excluded alternative diagnoses. These are internationally verified definitions. So Ratko presented some really nice data from UBioPred on sputum phenotyping in severe asthma. Many of you will have seen this, the first, in the modern era, phenotyping study of severe asthma published getting on for 20 years ago now, I think, and where asthma clusters were defined from this really seminal study from the Leicester group, showing different clusters of asthma which could be defined according to symptom load and eosinophilic inflammation. And many of the patients that we're going to be talking about today with severe asthma who may be candidates for biologics are towards the right-hand side of the graph. And we'll be talking about these in more detail. So we have some great therapies now for severe asthma, and I know that, as I say, we're lucky in the United Kingdom to have access to most of them. So this is what they do. These are two meta-analyses here. On the left-hand side, it shows you that they lower the asthma exacerbation rate by up to almost 80%. Doesn't matter which drug you pick. And then on the right-hand side, the majority of patients in these studies will achieve maintenance oral corticosteroid cessation. So they are very powerful drugs which can make a massive difference to patients. This study shows, however, that global access to biologics varies. The International Severe Asthma Registry Group constructed a biologics accessibility score, a BACS, to compare biologics access between different countries, and you can see the differences between the different countries over there on the left-hand side. And not surprisingly, The differences between accessibility differ depending on biomarker thresholds, and Ratko's already alluded to the fact that in the United Kingdom we have quite high thresholds for access to biologics compared to some other countries. Exacerbation requirements, the need for long-term oral corticosteroids, and other definitions of severity and control. But there's a real disconnect between GDP and the BAC score, as you would imagine. This is our biologic algorithm, if you like, or map of biologics available in the United Kingdom. And I put this one up purely to show you just how our regulatory environment works. We need, for example, upwards of 3 exacerbations and strict criteria on blood eosinophils. We've one biologic now, tezepelumab, that doesn't have any qualifying biomarker entry criteria, but the majority do. And there are some other restrictions, for example, in the use of the anti-IL-4/13 drug dupilumab, in that we're not allowed to use that in patients who are on therapeutic maintenance dose of steroids. So it's quite a complicated environment and quite strictly regulated. So what does a typical patient in our asthma service look like? We do have a very useful resource in the United Kingdom called the Severe Asthma Registry, and every time we prescribe a biologic, we have to upload data to this registry. This does mean that the registry is biased towards containing data on patients who are going on to a biologic. We have fewer patients who are not on biologics or not going to be on biologics, so it's a bit of a biased data set. But it does give you a pretty informative picture as to what our patients look like. You can see that the average age is 50 years. The age of onset of asthma is 24 years. So your average patient is taking more than 20 years to get to specialist assessment before they get their biologic. And I think we all know patients with severe asthma, and I don't think anybody's suggesting that they're developing their severe asthma in the 19th year of that trajectory. In other words, they're going to have severe asthma, poorly controlled for many years before it's recognized and they're referred in a country with good access to biologics. So we have a system problem which we can begin to pick apart using this national data set. We can also see that we have a very high level of comorbidity, lots of gastroesophageal reflux disease, lots of nasal polyposis, very high levels of depression and anxiety. And personally, I don't think that that level of 8.3% depression and anxiety really captures the daily experience that I feel when I do my severe asthma clinic on a Monday and a Friday. If I tell you that our standard workup panel for the severe asthma patient is going to be an Epworth score to screen for obstructive sleep apnea, an HbA1c to screen for pre-diabetes or diabetes, a reflux score, liver function tests, and a FIB4 to look for hepatic steatosis. It tells you that we are dealing with much more than severe asthma in the clinic. And we are the patient's first port of call after a long delay, and so it's our job to help them with all those comorbidities. And that's why we have a team of people to try and best manage the whole patient. The average BMI in a UK severe asthma clinic is 31, and therefore, that's a significant amount of work and effort required to help patients with weight control as well. The majority of patients, of course, are going to be biomarker high, T2 biomarker high. But the next slide shows some further data. It shows that this was published 4 years ago, which was well into our modern biologic era in the UK. At this point, we'd had mepolizumab on market for 5 years, omalizumab, of course, for much longer than that. And we'd also had a couple of years of benralizumab as well. And despite that, at registration, the majority of patients, there was a very high level of oral corticosteroid use. 52% of patients were on maintenance prednisolone at a median dose of 10 milligrams. So therefore, we're getting patients far too late, despite all the drugs and mechanisms being in place. I'm going to just move over to the other side of the slide here to just talk about the patients that were characterized on the database as being T2 low. In other words, at registration, they did not have elevated levels of eosinophils, so they did not have a high pheno. But if we look at this group, they are doing equally badly. They've got very high levels of oral steroid use. Obviously, in this group, there's a bit more, the rates of smoking are a bit higher. They've got equally high BMI, 32, high levels of depression and anxiety, and they're equally obstructed. Now, this was at a time when we didn't have a biologic for T2 low asthma. We didn't have access to tezepelumab. But what the authors did in this study is they then took those patients and looked back historically on each of those patients in the T2 low group, and they found that actually at some point they'd been T2 high. So in other words, they'd been, if you like, misclassified as not being as missing out on a biologic, whereas in fact they probably were over-treated, and if you took some of that treatment away, they'd be able to show you that they were T2 high and might have access to a biologic. So this data can really help inform some of the gaps in care in the United Kingdom. So I'd like to say something about oral steroids. And so I think Ratko's already alluded to the fact that we have quite strict guidelines, strict criteria for use of biologics in the United Kingdom. And the NICE, or the National Institute for Clinical and Healthcare Excellence, tends to set what's called a quality adjusted life year threshold of £30,000. So that means that if they're going to license a treatment, and it doesn't matter whether it's a treatment for the eye, an operation, or an asthma biologic, they're looking for a health economic benefit of £30,000 per year, taking into account the drug costs, the system costs, and so forth. What they weren't able to do to date is actually factor in the costs of oral steroid usage and the cost of the comorbidities associated with oral steroid use. You're at an early stage in this country in your journey towards biologics, and I wish you all the success with that. It would be great if you were able to, in your arguments with government, include oral corticosteroid-related healthcare costs, and we've got some data on that, and the data is quite startling. So firstly, and I think over the years, we've all grown up with steroids being life-saving, and I think we've all been guilty, before biologics, of what I would call therapeutic nihilism. In other words, it's just another course of steroids, isn't it? It'll be okay. But what we've now got is really precise data on the relationship between cumulative oral corticosteroid use and risk of side effects, and I'm going to show you some of that data now. This is a very powerful study led by David Price, who's a very prolific publisher of asthma studies, particularly relating to using general practice cohort data, so family doctor data, and using the NHS mechanism, he can access thousands of case records and enabling you to do very innovative studies. And what he was able to show in this study is that there's a dose-response relationship for cumulative systemic corticosteroid exposure, with most adverse outcomes beginning at a cumulative exposure of between 1 and 2.5 grams of prednisolone, which is equivalent to 4 lifetime courses of systemic corticosteroids. Okay, that would be, looking at our average patient that we showed you just now, 1 year's worth of steroid exposure, 4 courses. We've already said that patients are taking 20 years to get to us. So are they getting to us 19 years too late? So very powerful data. There's been some further research on this. Some papers have shown the risk of an OCS-related adverse outcome is now measurable at a cohort level after a single dose. Now, when I talk to patients, I'm very careful to say steroids are life-saving. You know, you don't want to frighten them too much. They are life-saving, but we're lucky we've got some further treatments that we can use to help reduce the use. But you have got to present the information to the patient carefully when you're talking about this. We know that adherence to inhaled corticosteroids, which of course can save your use of systemic steroids, are low. We also have some data on oral corticosteroid use trajectories, and over 10 years, most patients with at least one course of steroids at the beginning per year transition to frequent prescription. So in other words, if you've got a patient in front of you, they've had bad asthma and over the past 2 years, they've had 2 to 3 courses of steroids, it's a fair likelihood that they're going to continue in that vein. It's not just magically going to get better. So you've got to think about whether you can do something else. Is it coming? Okay. This is just some of the data from the Heath-Heatley study from just 2 years ago, showing the odds ratios for various adverse events, depending on whether you've had one course of oral steroids, a few, or frequent. And you can see as you go from yellow, blue to green, the odds ratios increase, and you've got everything here from pneumonia, sleep apnea, glaucoma, cataracts, cardiovascular disease, peptic ulcer, all the side effects that we know about. So this is hard data. I really like this study. This was put together by Liam Heaney, who runs Professor Liam Heaney in Belfast, who's published a great deal on steroid adherence in asthma. Number of other publications, too numerous to cite, actually, but has recently done some work on something called the glucocorticoid toxicity index. This is an index actually developed for patients with rheumatoid arthritis to summarize at patient level the weight of side effects and adverse effects related to oral corticosteroid use in that patient. And the question is whether giving a biologic will actually reverse that. Does it send your GTI back to zero? And the short answer is, and we know patients, we know that the steroid side effects we're seeing are largely baked in. The clear answer from the study is that biologics will not reverse this. So it's a way of quantifying what we already know. Early treatment is going to be better. Here are some of the costs. And so if one looks at patients, this is an average daily exposure to prednisolone. In the red bar at the end, we've got patients on more than 15 milligrams of prednisolone per day. And on the left-hand axis, we have annualized all-cause adverse outcome associated costs. In other words, what are the costs of those comorbidities per patient for each of these steroid groups? And as you can see, as the oral steroid dose goes up, so does the healthcare cost. And so if you're on 15 milligrams of prednisolone a day, you've got an additional healthcare cost of £4,000 a year. That wasn't factored into the nice economic analyses that have been done for any of the asthma biologics in the UK, because that data wasn't there then. And I think it would be really interesting for us to do that all again. I'm sure it's not going to happen again, but I think that could result in a different quality-adjusted life year outcome. We may have got more easier thresholds. And if you can use some data similar to that in your efforts to gain access to these drugs, I think it could be useful. So we all sit in hospitals, but what's happening in primary care, our family doctor system? And again, John Busby and David Price did this very nice study looking at oral corticosteroid use both in severe asthma centres and also in family doctor centres and in local primary care, your general practitioner. And what they found actually was that in primary care, despite patients being, according to the data that I had, T2 low, so low blood eosinophil count and where possible low FeNO, there was still a very high level of maintenance oral corticosteroid use, 30%. So either low biomarkers or no biomarkers. Again, this comes back to oral corticosteroid stewardship. These patients we saw this particularly in the pandemic, actually. Patients would call their GP to say, I'm having an asthma attack. They would not even come to the doctor to have their chest auscultated. The diagnosis might even have been wrong, and they were prescribed oral steroids remotely because of the constrictions around pandemic access to medical services. But that's actually, it got worse in the pandemic, but it's a long story and it continues to this day. So there's something around education of doctors, of implementation in family systems for implementation of pheno, measuring the blood eosinophil count and getting the diagnosis right. Something that we really need to attack and change in our primary care system to make sure that we get oral steroid stewardship. And again, I think there's something also around patient expectation and patient education, because early on in the career of a patient with asthma, they are taught to take steroids, and there can be a sort of relationship whereby it's another attack, let's have a course of steroids. As Ratko very, very pertinently said, it may be rhinosinusitis. You know, don't assume that this is another asthma attack. There's also an issue when we've got patients on biologics, and you know, if you haven't sorted out their dysfunctional breathing or haven't isolated their inducible laryngeal obstruction, they have another asthma attack, they have another chest attack, they get steroids. And unless you're actually seeing that patient to pick it apart, you might have had a wonderful physiological inflammatory response to your biologic, but you're still having courses of steroids and the patient's being treated for the wrong thing. So, complicated issue, and we can see good oral prednisolone stewardship is an issue right across the board. I think that just summarizes what I've just said. So, in my last 10 minutes, I'm going to talk a little bit about inequalities and access to care and outcomes. And I think inequalities in access to care is a huge topic. And you could take it in so many different directions, depending on the audience, depending on where in the world you're speaking, depending on your focus. So I'm just going to talk about the UK experience in terms of inequalities in access to severe asthma therapies in the main, and some of the data that we have from the UK Severe Asthma Registry on differences by ethnicity and also differences by location. Well, I appreciate I really cannot do justice to this topic in even half an hour. I will then be talking about some of the data-driven solutions that we're looking at in terms of improving access to severe asthma care in the United Kingdom. So, this is just a random snapshot of some of the studies looking at inequalities in access to care and outcomes. And of course, we're all very familiar with the large literature on access to care, with many studies coming out of the United States of America on racial disparities in terms of access to, in terms of asthma outcomes and in terms of access to care. They're now beginning to publish some very interesting studies on race and ethnicity and insurance type and access to biologics. I think this is relevant for all of us to consider, but of course it's a very different healthcare system, so not directly necessarily applicable to the UK. One of the strengths of the UK healthcare system is that we have for many years collected hospital episode statistics. And so every time a patient is admitted to hospital with an asthma attack or a COPD attack or a pneumonia attack, that's registered, it's measured. And we've been doing that for years. What's interesting is that we haven't always done a great deal with that data, but we are beginning to use it now to look more specifically at asthma. In the last few years, there's been a much greater push in the NHS to look at indices of deprivation. And we can map the whole of the United Kingdom according to economic deprivation index. And there's a scale of from 1 to 5, and if you're in group 1, you're in the most economically deprived quintile, and if you're in number 5, you're in a slightly better group. And this is data simply on asthma admissions per 100,000 of the population over several time periods, 1, 2, 3, 4, 5. These are quarterly data, I think, spanning a 2-year period. And you can see that it doesn't matter when you measure it, but for every single time point, there's a big difference between asthma admissions depending on whether you're in the most deprived group or the least deprived group. What this data allows us to do is to plan services, and so where resources are limited, and we are lucky to be relatively well resourced in the United Kingdom, but we do have to apportion money in the most needy location. We've been able to use this data, for example, to put a nitric oxide machine into those areas which have the highest asthma exacerbation rate and really target those primary care practices where outcomes are poorer. And by extension, the prevalence of severe asthma or difficult asthma will be higher. I'd be interested to know whether you have similar data here in Bosnia and Herzegovina that would allow you to do that, because it can be quite powerful. In terms of other inequalities, again, this is related, and this is where media and isolated cases, high-profile cases, can change policy. These two cases of these two poor, unfortunate young people who died from asthma became very high-profile, and at the top, this was A.Y. Bishop was a 2-year-old young boy living in that house in Rochdale, which is an area of the northwest of England. It's a very it's part of the Greater Manchester area with high levels of deprivation and in particular high levels of poor housing. He died after a couple of admissions to hospital, had a respiratory arrest, and the coroner investigated his death, and his home looked like that. So there was deep contamination by black mold. And this has led to a change in the law, which now has strengthened the law to mandate those looking after social care housing to ensure that that environmental remediation is done in patients with poor housing. The next case also highlights geographical inequalities in a way. Ella Adu Kisi Debra was, I think, 12 years old when she died of bad asthma. And she had had numerous admissions to hospital in the South London area with bad asthma. And the coroner asked Professor Stephen Holgate to investigate her death. And what he found was that there was a temporal relationship between illegally high air pollution and asthma exacerbations. And so every time she was in hospital, the local where she was living air pollution level had gone sky high. And that led to the first registration of death in the United Kingdom with a cause of air pollution. So I'm really interested in how this comes back to your conversation from GAP and with Tonya talking about patient advocacy. Highly relevant here. This was all going on, and a few years later, the ULEZ, or ultra low emission zone in London, which mandates pollution limits on cars entering London, lest they be fined. There was a major political pushback against that, and that was successfully fought, and ULEZ has now been expanded successfully, meaning that the people in London can use cleaner air. So I know we're getting into housing and economic and social policy. We're getting into pollution limits here, but I think it's a very nice example of bringing in patient advocacy in a way that I don't think we're able to do when we see the patient sitting in front of us. So moving on a bit more to biologics, and this is again how we use data to try and improve care in the United Kingdom. And it's really interesting how even within one country, I hesitate to say that the United Kingdom is one country. I think it depends on whether you're Welsh, Scottish, or Northern Irish, but one country, let's leave it at that. We have actually slightly different health systems. And if we look at those different health systems and look at the proportion of patients accessing biologics for severe asthma. In England, where we have quite tight, restrictive systems in some ways, we think we've got access to biologics out to around about 17 or 17% of the people who are eligible. So this is a rather sobering thought, because I've been doing this now for some, at least 10 years, and I think I would need to live till about 120 before we get through everybody, and then there'll be a new cohort. So we need to change what we're doing. Scotland, which is actually above that bit, right at the top of that map, has a slightly different system, and they've managed to achieve, in the same time period, 30% biopenetration. So there's still a long way to go, but we can see big differences in access to these important drugs within one landmass. And again, as you're setting up your services, I think be interesting to see whether you can draw some conclusions and lessons from our experience. We are just about to change our national service spec to reorganize things so that we make it quicker for patients to get access to these drugs. It's not straightforward. I think I've already said this, but this is actually a nice study from Dermot Ryan, a general practitioner who's got, a long record of publishing in the area of both allergy and severe asthma in the United Kingdom. He quite simply revealed that the majority of patients with severe asthma are just simply not referred. They're not recognized and they're not referred. And so I know there's a tendency, isn't there, to think about biologics and phenotyping, and it's all quite complicated. We talked about refining diagnoses and so forth, but at a practical level, if you've got the patient in front of you, think, have they had 2 courses or more of prednisolone? Measure the blood eosinophil count. Have you confirmed airflow obstruction at some point? And if you haven't, try and go about confirming it. And then you'll be most of the way there to getting that patient onto their journey towards better treatment. So it's the elemental bits are not difficult. Sometimes the access to spirometry is difficult, and even in the United Kingdom we struggle with that. We've got whole programs to roll out spirometry, but the elements of identifying the at-risk patient shouldn't be too difficult. Okay. We do see some ethnic differences among our severe asthma cohorts, and I'll just broadly focus on these just out of interest, really. They are important. The important thing is that once all patients get to a severe asthma centre, there doesn't seem to be any difference between ethnicities in terms of whether they're given a biologic, and you'd certainly hope that that wasn't the case. But we do see in sort of non-Caucasian groups higher emergency healthcare use, higher T2 inflammation, interestingly, worse lung function, and a worse baseline asthma control, and also less adherence to inhaled therapy. So we can use this sort of information to help hone our approach to our local populations. I'm going to just skip that one. So almost towards the end, I'm going to talk briefly about remission. We'll be talking about this a little bit more tomorrow. Ratko has already mentioned this, of course. There was a lot of debate among the severe asthma doctor community when the concept of asthma remission was proposed 4 or 5 years ago. And I think some doctors were actually afraid that the use of the word remission, with which we're most familiar with it, is in the context of cancer, might cause some fear. And there might be some fear if you then had remission, but then you had your first asthma attack afterwards and you then failed remission. I think the one difference in me as a doctor now and a doctor 20 years ago, other than the fact that I've got a bit more patient experience, is I much more appreciate the concept and the importance of hope. And I think we spend a lot of our time in our clinics now not only telling the patient what's wrong with them and exploring therapies, but also offering hope. And I don't think you can put a price on that. And I think we found that patients like this term remission because it gives them a hope. Wouldn't that be wonderful to be labelled with remission? There are various different definitions. I won't go into them now, but essentially it's all about better asthma control score, getting off steroids, being exacerbation-free, and with or without an improvement in lung function, which, as we've already alluded to, is quite difficult to achieve. And there are differences in your likelihood of achieving a remission. In this one study, which again, as I recall, is a UK Severe Asthma Network study, if you're, not surprising, if you're a smoker, you're less likely to achieve it. But if you have a longer duration of asthma or a higher baseline symptom load, you are less likely to achieve it. So again, a big argument for getting patients sooner. Okay, so solutions. Yeah, so I mean, it's now possible to predict asthma risk using very, very easily, very, very simple tools. This study from Couillard and Ian Pavord in Oxford showed nicely that you can predict the risk of an asthma attack using whether you've had an asthma attack last year, peripheral blood eosinophil count, exhaled nitric oxide. Whereas with our biologic criteria algorithm, you have to wait until you've had 3 or 4 courses of prednisolone. So we've got a crisis-led response to biologic authorization versus the potential for a purely risk-based algorithm which could treat you before you ever get to that point. And that's really the way in which medicine should be using. We've got the science now, we need to make the case. This is related, again, using that local exacerbation data, we've been able to, in the United Kingdom, pinpoint those areas of high need, high asthma admission data and target them for using as required inhaled corticosteroid reliever therapy, so-called MART therapy. And if you do this in a systematic way using regional data, you can actually make a real difference to patient care. The update of MART therapy goes up, and you begin to see improvements on a regional level in terms of asthma admissions and asthma control. And this is data from our region in the east of England, and we've shown that over the last 2 years there's been a steady decline in each of our sub-regions in the use of SABA use. And so it's not all about reducing unmet need. It's not all about railroading in biologics, but it's also about looking at systems use of other medicines. We want to do the same thing with looking at oral corticosteroid prescriptions and being able to pinpoint localities of high use. That's a bit more difficult to do because, of course, prednisolone is used for rheumatoid arthritis, COPD, asthma, temporal arteritis, you name it. But that's what we're aiming to do, to again, at a regional level, drill down on those areas that are performing badly. And I think I'll just summarize now by saying that, although we're in a fortunate position in the UK and biologics can be life-changing, we have got a real problem with getting blanket cover, getting 100% coverage to those patients. We've got a long way to go. We can use national and regional data to outline those areas where we're doing worse, and we can use regional health policy to try and affect change. But it's a long journey. Thank you.
Thank you, Robin. That was a